coming today. I know some of you come from a long distance, and I'll do my best to make it worth your time. I'm Charlie Eaton. I'm the founder and director of the Dupuytren Research Group, and our goal is to make a difference with people that are struggling with Dupuytren. And oh, there we go. And so this is what I'm going to talk about today: issues with Dupuytren disease and the field of research for a cure. I'm going to talk about these and a couple other things, but what is Dupuytren? Who gets it? What's the timeline? What may get involved with slowing it down or stopping its progression? How do doctors currently treat it? And what do we have to do to develop better treatment options? Dupuytren Research Group is a 501c3 nonprofit, public charity established in 2008. We are patient-run and patient-governed. Our mission is to do what needs to be done to develop a Dupuytren cure. We have no commercial ties. I don't have any financial interests in this. I'm just an advocate. So we'll start off with the word Dupuytren, strange word. And Dupuytren was a French surgeon who was, in his lifetime, the most famous surgeon in Europe. And in the early 1800s, he described an operation for this condition, which really hadn't been named. He wasn't the first to describe an operation, but he was really famous. And so the condition got tagged with his name. The Dupuytren disease is the underlying process that people have that may go on to develop nodules in the palm and may develop contractures in the fingers. So the nodules, or what's going on before people get nodules, is Dupuytren disease, and the contracture is the deformity that happens when the tissue under the skin tightens up. Dupuytren is a chronic medical disease, and this is I say this because it's genetic. It runs in families. There's some evidence to suggest that there are some genes that seem to be involved. It's systemic. There are some health issues associated with it. So it's not just in the hands. There is, it's multifocal, which means it shows up in different locations. So people with Dupuytren are at increased risk for having its sister condition, Ledderhose, in the feet. And in women, there's an increased risk of frozen shoulder, although the exact relationship with Dupuytren isn't known. And in men, there's a relationship with Peyronie disease that affects the penis. The exact relationship of that also isn't known. The thing that's most clearly associated is Dupuytren and Ledderhose. They really seem to be different locations of the same problem. The Dupuytren, when you talk about Dupuytren, the main focus is the palm of the hand. That's where most of the action is. The first findings in Dupuytren are typically nodules in the palm. Now, a nodule is a hard area that usually is located along the line of, if you take a line that goes down the finger and then down into the palm, nodules are usually along those lines. And this area of the palm is common to get nodules, but people can also get them out in their fingers. Usually just in this part of the finger, usually not up to the middle bone or the end bone. And I've got these areas X'd out because there can be some confusion, because people can get other bumps in their palm that aren't nodules. So the areas in between the fingers there that are marked with an X are not nodules. And the reason that people get those is somebody will have Dupuytren along the line of a finger, along the line of adjacent fingers, and it tightens up the tissue in those areas. And in between the fingers, there's a little fat pad that cushions the nerves and arteries that go out to the fingers and allows them to move around. When you bend your fingers, they can kind of get out of the way. So when you have tightness, excuse me, when you have tightness on this finger and on this finger, then the fat in between those pooches out. So that's actually normal tissue, and it's a cause for concern of some people. They have this bump and they think, oh my gosh, I've got a nodule. But the obvious thing is that they're not hard, they're soft. If nodules progress, and they don't always progress, but if they do, then the next stage is tightening along the line of a finger. And that tightening is accumulation of a scar-like tissue. It's not quite scar tissue that pulls up from the palm, and it can be firm. But oftentimes, if you let your fingers relax, it's hard to feel. You can really only feel it when you straighten your fingers, kind of like a rope. If it's not taut, you can't feel it. But if it is taut, it feels hard, even though it's not actually hard. If cords progress, and they don't always progress, but if they do, then the cord can shrink and tether the finger down so that you can't straighten it up all the way. And typically people can make a fist, they just can't straighten the finger up all the way. And that is the Dupuytren contracture. The difference between the two also is that nodules are really collections of cells. They're not a structural change in the hand. They're just a collection of these special kind of repair cells that are involved with Dupuytren. Whereas cords, whether they're pulling the finger down or not, those are accumulations of this scar-like tissue, which is a structural change in the hand. So if you had some kind of treatment to make the nodules that would work on the nodules, that may make them smaller or even go away. Whether or not that changes the progression over time really isn't known. But you can't, the only way to deal with the cords is to do something physical to them. People can get nodules in other parts of their hands. So people can get nodules on the backs of their fingers, right over this area here, and those are called knuckle pads. It's the same kind of biology. People can also have Ledderhose, which I mentioned, which is lumps in the arch of the foot here or even further up. And those lumps tend to be bigger than the lumps you get in the palms. It's all the same biology, but they behave differently. Dupuytren in the palm may pull the fingers down. Knuckle pads and Ledderhose disease don't. They are just lumps and they tend not to contract. And we can talk about that later, but there's a biologic reason for that, mechanical reason. Talk about the anatomy of what's going on. The skin of the palm is put together kind of like a quilt. And if you made a quilt, you'll follow this. If you haven't made a quilt, and you should, the way you do it is it's 3 layers, and you have a layer of cloth, and then you put on a layer of padding, or it's called batting, and then another layer of cloth, and then you put stitches going through all those layers. And depending on where the stitches are and how tight they are, you can make patterns on the surface. And so here in the palm, there aren't any stitches, so that's nice and loose. And then further out there are tighter areas that allow you to sculpt the contours. And the palm has a lot of similarities to that. So the skin of the palm has these creases in it, and those creases aren't just areas where the skin folds. Those are areas where you have extra attachments, like of little threads that hold the skin down, and more of those little threads. So that's why you see creases in the hand and also out in the fingers. It's the same type of construction. So if we looked at a cartoon breakdown of the hand, these colored areas are layers of tissue that are just under the skin. They're between the skin and the working parts of the hand. So just in a small depth beneath the skin. And I've got them colored in different colors because they have different names, and they're stacked one underneath each other. It'd be great if they were this color in real life. It would make surgery a lot easier. But they're not. They're all the same kind of whitish color. So I've got this area here blocked out because it's a good area to look at because it's a constellation of different structures. And so if we blow that up and look down on the surface, if we were able to roll that around, we'd see the connections between these layers. And you can see there's skin on the top. And then the first layer of fascia in green is underneath that. And the little connections between those are little threads of tissue, little fibers that anchor the undersurface of the skin down to the next layer below. And it can anchor to the fascia or it can anchor to other layers. And then under that green fascia is another layer of fascia which goes in a different direction. And then other layers of fascia which go in different directions. And then the lining of the bone, and then the bone itself. So if you look at this, there's actually a direct connection through these layers from the skin all the way down to the bones in the back of the hand or the finger bones. And this is why the skin of your palm, if you straighten your fingers as much as you can't move this skin around. You can't slide it around. the way you can on other parts of the body. And that's because all these little threads hold the skin down. And when you grab something and hold on to it, it's these layers underneath that keep it from moving. And in that case, what happens is the stress that holds the skin in place, the mechanical forces are absorbed by this layer that's just underneath the skin. And then this happens to everybody. But if people have a genetic profile that puts them at risk for having Dupuytren, then it can trigger this Dupuytren biology. And that's where people get nodules. And if the nodules contract, it shrinks the fascia under the skin, and also can shrink the skin or give dimples or things like that. So that's a simplification of what's going on mechanically in the hand. Dupuytren is a genetic condition. It runs in families, and as with other genetic conditions, it's considered a two-hit disease. So the first hit is a genetic predisposition, and that percolates along. The second hit is the straw that breaks the camel's back, usually a minor factor, but one that starts the process going. And the biggest factor is age. And the reason for that is that age isn't just things wearing out. Age is a genetic process that runs our entire life. So the changes in your body that occur from being an embryo to a fetus, to a kid, to unfortunately, a teenager, to an adult, those are all controlled by your genes. Not that the genes change, but there is a mechanism of switching genes on and off. And that's responsible for the entire aging of your life, from conception to death. Because this is a genetic process, and Dupuytren is a genetic process, it makes sense that over time, when people are at a certain stage of their life and certain genes are turned on and off, that may be the triggering factor for beginning the Dupuytren activity. There are other factors, such as an injury to the hand. People have a broken wrist, people have surgery on the palm, people have a bad fall on their hand without necessarily breaking anything. That may be followed by the first evidence of Dupuytren. Hard to say the relationship there, because we all injure ourselves regularly and then forget about it. I mean, that's what hands do. They're tough, they're on the front lines. But in people that have surgery on their hand, in particular, there's a study that came out recently that showed that people who had trigger finger surgery had a small but significant increase in the likelihood of having Dupuytren after that. If somebody already has Dupuytren and they injure their hand with a fall or something like that, then they may have a period in which the contracture accelerates and then usually stops. People that have injury-related Dupuytren, as far as we can tell, tend not to go on and on. It tends to be a more mild version of Dupuytren because it's triggered not by age, but by this external trauma. People who do heavy manual labor have a slight increase as well, but you have to be doing heavy manual labor 5 days a week for at least 10 years before it moves the needle. Chronic heavy smoking, chronic heavy drinking are associated, diabetes is associated, but all these are relatively small risk factors compared to age and compared to having the genes. So it's not clear how much of an influence they are. It's really like a straw on the camel's back. So let's look at some people that have Dupuytren. You may recognize some of these folks. We're going to start from the upper left. That's Samuel Beckett, the playwright who wrote Waiting for Godot. Next to him, Frank Sinatra, Joe Bonsall of the Oak Ridge Boys. I suspect Chris Pratt, definitely Bill Murray, most likely Vladimir Putin. Ronald Reagan had surgery for his Dupuytren when he was in office. Above him, actor Bill Nye, Mitt Romney, Chelsea Handler. Bottom left is physicist Max Planck. Above him, 60 Minutes correspondent Scott Pelley. That's a screenshot. Not bad, but it was a close-up because he was looking at something very tiny. You can see that little dot. And then to the left, Sam Elliott. So what do these folks have in common? One, they all obviously have European ancestry. Two, none of them have names that end in sen or son. And I say that because there's this commonly repeated trope that Dupuytren is a Viking disease. And this all started from, there was a surgeon, John Houston, who was wrote a lot about Dupuytren. He was a big Dupuytren guy. in the 70s and 80s, and he had a speculative bit in one of his textbook chapters. He floated the idea that, well, Dupuytren's more common as you get more north of Europe, so maybe it was spread by the Vikings. No evidence at all. But it made good copy, and people took it and ran. So if you look through Dupuytren literature, on last count, there were over 80 articles that I found that just said it's a Viking disease, but there's no evidence. And so let's put this to rest. Really interesting study done in 2015, looking at migration patterns and the genetics of migration patterns from the Scandinavian countries to the British Isles. And you can see the folks in the Norway area and the folks in the Denmark area, the colors of those and where they tended to settle. The blue dots in the middle are areas of particularly high concentrations of Scandinavian names and family names. And Michael Ing published a study a few years later where he looked at the prevalence of Dupuytren in the British Isles and this genetic risk score that they were looking at. And the differences in these areas aren't, this heat map exaggerates the differences in the area, but the conclusion is this map and this map have no correlation other than the shape of the British Isles. So, there's no evidence that it's a Viking disease looking at modern data. What Leslie also found was that the Vikings weren't genetically monolithic. They weren't one family. There were people from all over Europe who participated in these Viking adventures. She also concluded that the Celts were not a familial entity, but it was a cultural thing. So don't blame or claim Viking or Celtish heritage if you have Dupuytren. Ancestry does affect Dupuytren risk. In the United States, European Americans have the highest risk. Compared to European Americans, Hispanic Americans have about a third the risk, African Americans about 1/5 the risk. The corollary of that is the average African American has about 1/5 European heritage. So that fits together nicely. And Asian Americans, 1/10 the risk, at least when the study was done. This is not unexpected. Dupuytren is a heritable fibrotic disease. Fibrotic diseases are ones that cause scarring-like tissue where it shouldn't be. And some of these diseases are more common in people of non-European ancestry. Some of them are more common in people of European ancestry, and some of them hunt in packs. Dupuytren, Peyronie, Ledderhose, and frozen shoulder tend to be clustered, and they are clustered in people of European descent. The risk of Dupuytren also depends on your gender and your age. The reason that gender is involved isn't really clear, but after the age 40, the prevalence of Dupuytren goes up fairly steadily in men. So men in their 50s have about a 1 in 10 chance of having some evidence of Dupuytren. Most of them, it's very mild, and most of them no bent fingers. That number goes up to 1 in 4 of European ancestry men in their 70s. And women, the curve does go up, but they tend to start 10, 15 years later on average. So once it's activated, they increase about the same rate as men. A couple different possible reasons for this. There's knowledge that estrogen has a regulatory effect on collagen metabolism. Collagen is the main protein in there. One of the enzymes that is involved with Dupuytren biology is located on the X chromosome. We don't know yet, but we do have this evidence that's the case. So you might say, well, it's more common in men than women, but it's not that simple because the curves go up. And so early on, you look at Dupuytren in people in their 40s, it's almost entirely men. In the 50s, men outnumber women about 10 to 1. In the 60s, about 4 to 1. 70s, about twice as common in men. And then because women live longer than men, and men kind of start dropping out at that level, if you look at people in their 80s, where women outnumber men 2 to 1 for people in their 80s, it's the absolute number of women with Dupuytren is higher than the absolute number of men. So if you say, well, it's more common in men than women, you really have to ask what age. I know this sounds like a crazy question, but what is it for? What's the purpose of it? And because people that have genetic diseases, if someone has a genetic condition that impacts their health or makes them not live as long or makes them not have as many kids, then over generations and generations, those genes tend to get weeded out. They're not passed on as much. But there are conditions in which there are a lot of folks with genes that seem to make people sick. And so the question is, why, how does this apply to Dupuytren? Well, there's some examples of this in play. One example is sickle cell anemia. The sickle cell anemia, very common in Africa. And when someone has sickle cell, the gene makes the red blood cells not normal, kind of a different shape, and abnormal in other ways. So it's just one gene that's involved. So a person gets one gene from one parent, but a normal gene from the other parent, then half of their red blood cells have this sickle change and the others are normal. If they have the sickle cell gene from both parents and they have both of those genes, and those people are sick. They don't have normal lives. They tend not to live long. They tend to not have kids. And it's a terrible, terrible thing to have. Sickle cell is sometimes called sick as hell anemia. And so, but there's a fair number of folks who have these genes. Why would that be? Why wasn't it weeded out? And the answer is it's the cost of doing business with malaria. So when malaria is pretty common in Africa as well. So when someone develops malaria, and malaria is a bad disease. You can die within days of getting malaria, and the malaria bugs grow in the red blood cells. And so if all the red blood cells are normal, then they're all susceptible to being infected with malaria. And that's a lethal thing. If half of your blood cells have this sickle effect, they aren't infected by malaria. So if you have one gene, then that protects you from dying from malaria. So it's perpetuated in the cohort. And so that's why there are a fair number of people with the sickle gene, because if you have just one gene, you're more likely to live in an area with malaria than if you don't have any of those. Another example, more recently published, really interesting genetic archaeology study of people who lived and died just before the Black Death. They killed about half of Europe, and lived and died just after the Black Death, and looked at the genes in exhumed bodies and whatever was left, and looked at the genetic pattern in those two groups, and found that after the Black Death, there was a much higher percentage of people that had a small group of genes that affected the immune system. So those genes must have protected people from the Black Death, and people that didn't have those genes didn't make it. And those genes, it turns out, are involved with inflammatory bowel disease. They're immune related, and so they are involved with people getting ulcerative colitis and Crohn's disease and things like that. So for people that have those disorders, that's the cost of doing business with the Black Death. And that means that their ancestors survived the Black Death. So we don't know what. My suspicion is that Dupuytren causes problems has some kind of survival benefit, either in the past or some issue that we're dealing with right now that doctors haven't yet identified. So if you have Dupuytren, it's not a flaw. That means your ancestors were survivors and made it through some type of issue that otherwise challenged people. That's what I think. So if someone has Dupuytren, what's the timeline? What to expect? This is a cause of a lot of anxiety, because people will be diagnosed and then they'll think, oh, I'm stuck on a train track and the train's coming, and when is it going to happen? Is it coming fast? And we don't have a lot of information on this, but we don't have information on how fast people go from having Dupuytren before it's diagnosed. The hand will be normal, but the Dupuytren biology is already active. Going from that to having a nodule. If people have nodules, and if they progress to a contracture, which not everybody does, the average time to go from nodule to contracture is about 8 years. So we have that information. Once somebody has a contracture, we don't have really good information on how fast they go from a mild contracture to a more severe contracture. But we don't have that because surgeons treat Dupuytren, and if you go to a surgeon, they're not going to ask that. They just want to treat the Dupuytren, because that's why you're there. But not everyone progresses from nodule to contracture. And the numbers on this are, as far as we can tell, there's not a lot of data on this, but 2 publications distilling their results. Someone develops a nodule, 10 years later, about 1 in 10 palm nodules will go away on their own without any treatment. About 2 in 10 will progress to a bend in the finger that's bad enough that they'll either be ready for treatment or they'll already have had a corrective procedure. And the remaining 70% either have little or no change. So that's actually good news. But it'd be nice to know who's on what path when they're at the nodule stage. We don't yet have that information. We'll circle back to that. The treatment for Dupuytren, the accepted treatment that we have good evidence on is surgical procedures or mechanical procedures. There are 2 versions. The most common type of treatment currently is to do open surgery, open up the skin, and remove the tissue that looks abnormal. And that is called a fasciectomy. And there's a larger version of it in which you don't just remove the diseased tissue under the skin, but you also remove a fair bit of the affected skin and replace it with a full thickness skin graft, which is a thick skin graft. It's thick enough that it may have hair in it, so people may grow hair out of it. That may actually be a protective effect on Dupuytren because, taking a little detour here, the skin of the palm doesn't have hair follicles in it. The skin on the sole of the feet doesn't have hair follicles in it. And the skin here, a study in 2015 showed that the skin where people get knuckle pads also has no hair follicles on it. So that may be part of the story. We really don't know, but that also might be when you put a skin graft on an area of Dupuytren that has hair follicles in it, that may modify the biology, although it's a weird thing to have. Well, and you could make the case, well, maybe you shouldn't have a hair removal. You know, you can get electrolysis for hairs. I'm not sure that we'll see, but there are a number of things going on in the skin that appear to have a relationship with Dupuytren. The reason hair follicles are important is that hair follicles make a special protein, class of proteins called bone morphogenic protein that can transform the abnormal cells in Dupuytren, called myofibroblasts, can transform those into fat cells, which is kind of what you'd want. We'll circle back to that. The other version of treatment is a minimally invasive treatment. The most common one is an injection of an enzyme that weakens the tissue. And in the States, this is sold as Xiaflex. And the way it works is the doctor injects this enzyme into the cord and lets it soak in for a day or even up to a week. And then you come back, ideally have your hand numbed up, and then the doctor pulls on the finger, and that cord has been weakened. And so when you pull on it, it tears apart like a section of rotten rope. And that allows the finger to straighten out. And it's an office procedure as opposed to fasciectomy, which is in the operating room. The other version of this is called a needle fasciotomy or needle aponeurotomy or needle release. And what that is the doctor uses a hypodermic needle, a small hypodermic needle that has little cutting edges on the tip, and uses that like a miniature scalpel and numbs up the skin and goes through the skin with the needle, can feel the cord, and then can graze across the surface to weaken it so it cuts through it. And then you pull on the finger and it pops open. So they're essentially the same idea of lengthening the cord, disrupting the cord so you can straighten your finger. The comparison is that the open surgery lasts longer on average before someone has a recurrence. But it's a longer recovery, usually months, sometimes longer, and it has a higher complication rate. So the risk of having a permanent complication from an open surgery is around 1 to 2%. And that's permanent numbness or other issues with the hand. Not necessarily terrible, but it's an issue. Comparatively, minimally invasive procedures have a quick recovery, days or weeks for both of the minimal procedures. The complication rate is very low, around 0.1%. But the problem is that it doesn't last as long before it comes back. So neither procedure is perfect, and it's a matter of individual choice and surgeon's choice which way you'd proceed. Recurrence is the big problem with Dupuytren. It's the elephant in the room because this is the unsolved problem. It's also the main driver of complications, because if you have treatment and it comes back and you have another treatment, it comes back, and every time you have a treatment, there's a risk of a complication. you get this cumulative risk for having complications over your lifetime. And the numbers are, these are very ballpark numbers because recurrence depends on the joints and fingers and how bad the bend is. But overall, the risk of having a recurrence after a minimally invasive procedure is 10 to 20% per year on an ongoing basis. So you can't say, what's the risk of having a recurrence? Oh, it's 20%. You have to know what period of time it is because it's cumulative over time. Fasciectomy recurrence is about half that. And dermofasciectomy is much less than that. But as you go from minimal to big surgery, it lasts longer, but the risk of having permanent complications goes up. And so that's the unsolved problem. The anatomy affects the outcome. We'll look at a couple different versions of this. So the PIP joint is this little joint in the middle of the finger, and that is a bad actor compared to the MCP joint, your big knuckle that you'd punch somebody with. And it's a bad actor because it's harder to get straight with a procedure, and it doesn't stay straight as long compared to your big knuckles. The angle also makes a difference. The sweet spot to get the best chance of having a straight finger with the corrective procedure is when the joint is in the range of 20 to 40 degrees. That at that point, there's no other changes going on in the joint. When you have the PIP joint, if you have a bend that's 60 degrees or more, what happens over time is away from the Dupuytren, the joint itself changes, and the ligaments and tendons can be damaged by just being in this position for a long period of time. And that affects your ability to get the finger straight. Anatomy also affects how fast it progresses. And this is a little geometric thing. I know it's a complicated picture, but an angle that has a distance change, that has a length change at a distance from the angle, the amount of angle change depends on how close this length changes. So let's say this is a chord and it shortens by this much. And this is a chord and it shortens by the same amount. Well, the chord that is closer to the joint, this red bit, has much more of an angular change. And so based on that, you'd expect people that fingers that are smaller and joints that are smaller would have more rapid progression. And that's kind of what we see because the map down at the bottom, the blue chords are chords that run up the middle of the finger, and the pink chords are ones that run up the side of the finger. And so chords that run up the side of the finger would also be expected. They're closer to the pivot point of the joint. Those would be expected to progress more rapidly. And because the pinky finger is the smallest finger, it's the worst actor, the ring finger next, and then the other two are pretty similar. So these are all factors that influence the behavior of Dupuytren. So anatomy and biology impact the outcomes. So anatomy, how bad the bend is, that impacts primarily whether or not the finger will get straight. Biology is how easily the disease is triggered, how many straws it takes on the camel's back. And when you do an open surgery, that damages the tissue, that's a trauma, and that can provoke biology. So the biology is a big impact on whether the finger will stay straight after it's been corrected. I wish it were that simple, but the anatomy also can impact that, because if you have a lot of changes in the ligaments and tendon, you may get the finger straight, but if the anatomy is abnormal, if the joint's not normal afterward, in the first 3 months after after a procedure, you'll lose some of that straightening, some of that correction. So they both work together. Recontracture, that is having the bend come back, is not always recurrence of Dupuytren biology. So if someone has bad anatomy, they would be prone to having the bend, the finger recontract without having a biologic recurrence. So the woman on the left had bad bends in her fingers. She had a procedure to straighten them out, but the tissues around the PIP joints was damaged, so she didn't stay straight. Feeling her finger, there's no Dupuytren cord there. So this is not a Dupuytren recurrence, as opposed to the gentleman on the right who had a fasciectomy. And you can see right in the area of the fasciectomy has a recurrent cord. That's clearly recurrent Dupuytren biology, that's the thing that would be good to have a medicine to stop. Biologic severity, we don't have a good handle on. You'll hear about this diathesis word, which is a way that that doctors tried to predict the biology. And it came from Dr. Houston, the Viking guy, who looked at recurrence after his surgery. And he came to believe that people who had certain factors were more likely to have a recurrence after surgery. Those factors were having a strong family history of Dupuytren, having age of onset younger than 50, and having lumps outside the palm, like knuckle pads and Ledderhose. His thought was if people have this, they're not only at risk for having an early recurrence, but he assumed that that meant that they would progress more rapidly before they had treatment with no data. And that does not seem to be the case. So I mention this because somebody will have a nodule and they'll say, oh my gosh, my dad had Dupuytren. I have this Ledderhose nodule. So I must be one of those folks with diathesis and my fingers are going to just zip right down. It doesn't seem to be that way. It looks as though people that have these diathesis factors before they're treated don't seem to have any difference in how fast their fingers contract. And it doesn't seem to predict that. Back to the angles, they are a proxy for how bad the anatomy is. And the way that doctors measure this is with a protractor, like on the left, and also a common thing that allows people to follow their own Dupuytren is called the tabletop test. And with this, the idea is if you can put your palm flat down on a table and contact everything, you don't have a bad enough bend to talk about having surgery. And usually that break point is around 10, 20 degrees that you can't get your palm flat down. So you can have an abnormal tabletop test from an MCP contractor, from your big knuckle, from your PIP contracture, but it's not entirely reliable because if your MCP can hyperextend, it can hide or allow your PIP to bend, and you'd think that's a normal tabletop test, but actually it's not because there's a PIP contracture. So that's one of the loopholes of the tabletop test. And Dupuytren angles are complicated. So you can have a cord that spans sequential joints. And then you can have a situation in which you can straighten one joint or the other joint, just not both at the same time. That's pretty obvious when the cord affects your big knuckle and your PIP joint. But there's another joint on the ring and pinky finger down here in the palm that we can't really measure that can also be involved. This joint, it's called the CMC joint. There won't be a test after this, but it's the one that allows you to cup your palm, and it allows you to, when you make a fist, back of your hand is normally flat, but when you make a fist, it drops the pinky and ring finger down, so you have this curve, and mechanically that gives you a stronger grip, because otherwise you have a cylindrical grip. You have a cylinder on a flat surface on one end, and your other side would be pushing in, but this gives you a 3-point grip where you have 1 point here, 1 point here, and then push it up from below. So that makes it mechanically better. And showing the involvement of the carpometacarpal joint on the left, pushing this finger straight. And if you put the protractor on it, you say, oh, there's no bend in that finger. But there is a cord, and you can see the back of her hand is rounded. So she's flexing this joint, which a lot of people do. It's unconscious, just a normal thing. But when I push on the bone to straighten out that joint in her hand, that's what the angle comes out to. And we don't have a good measure of this angle. We don't have, it's another loophole that the angle measurements fall through. Great if it weren't this complicated. And angles also don't reflect a huge swath of issues that bother people with Dupuytren. There's anxiety about what's going to happen in the future. And that's a reasonable thing, particularly because we just don't know. We don't have good ways to predict. It doesn't reflect the fact that about a quarter of people with Dupuytren in their nodules will have tenderness, pain, itching, burning. It's not reported widely in the literature, but it clearly is an issue, and the angles don't show that up. People with Dupuytren, even in early stages, can notice they have problems with fine dexterity. And part of this has to do with the fact that the finger mechanics are slowly changing, and your brain is always playing catch up, trying to figure out, it's running the movement programs based on where it thinks your fingers are and how tight it thinks your tissues are, but they're different. So it's kind of like when you go through that clumsy stage in adolescence. I had a real tough problem with it. And the reason is your bones are changing length, and you think you're walking on bones on legs that are a certain length, but they're actually different. And so you mess up. And that is the same thing going on. One of the issues with dexterity, another little anatomy bit, is that you'll read that humans are the only primates with opposable thumbs. And that's not true. Opposition for opposable thumbs is taking a digit and flexing it and rotating it. So it opposes the other digits. So here, all my pads of my thumb and my fingers are facing this way, but when I swing my thumb around, it rotates so that I can bring the tip of my thumb against my index finger. There are a number of primates that can do that. What humans have that is different is we have opposition in other digits. So the index finger is able to oppose the thumb. It can flex and rotate so that you can get pulp to pulp pinch, precision pinch that primates can't do. And there's also opposition of the pinky finger through this carpometacarpal joint. The pinky finger can rotate over to touch the tip of the thumb and face to face rather than this. And that has an impact in terms of the span. Someone can have a tightness in the finger, but without a measurable contracture. But because their palm is cupped this way a little bit, then they can't stretch their fingers out as widely. And so people who play keyboards, they may notice, gosh, I've lost some of my span, but the doctor says I don't have a contracture, but they actually do. It's just not a contracture of the measurable joints. The other thing is that it's using typewriter keyboards or keyboards in general, not just piano. People complain that they hit the wrong keys and they have trouble with it. And we did a survey of people that complained of that and asked what keys they miss and what keys they hit instead. Plotted those out. And the yellow, the yellow are the pinky fingers. No, the yellow are I'm not a touch typer. The yellow are the ring fingers, and the green are the keys that are hit by the pinky. And if we plotted out which keys they tried to hit and which keys they actually hit, it follows exactly this path of the pinky finger swinging in that way. So this is yet another, all these things are missed by angles. And to just simplify it to, oh, we've got a 30-degree angle, misses really the things that bother people, because people aren't bothered by the angle, they're bothered by the effects of them. So we've covered some of the anatomy and some of the biology, and the way that surgeons try to operate is to match the person in an individual way with what they have to offer surgically. And this is in theory. So if someone has a mild bend in their finger and they've got a mild biology, then you can make the case to do a minimally invasive procedure. If they have a mild biology, but they've got a really bad bend, then for really bad bends, the open surgery works better a little bit than the minimally invasive procedures. And if someone has a really bad bend of the PIP joint, there is a gizmo that does skeletal traction that can pull the finger straight slowly. The device that's used most in the States is called the digit widget. And I'll show you a picture of it in a bit. That bolts into the finger bones and slowly over a couple months will straighten out that joint by stretching the fingers on the palm. That's skeletal traction. If somebody has bad biologic severity, and the diathesis factors don't really work that way, but if they have an early age of the first operation, you might make a case for doing dermofasciectomy as the first operation. The reason I mention this is that what happens is often the person will have surgery, they'll have recurrence, have a surgery again, they'll have another recurrence, and then the surgeon says, oh, I guess they have bad biology, so now we'll do a dermofasciectomy, which is a big operation. And because it's the third operation, the complication rate of that is pretty high. And so that gives this operation a bad reputation. But if you did it Earlier, you wouldn't have those complications. And the goal of treatment is to subject a person to the fewest operations over their lifetime. So because complications are cumulative, that would give them the fewest number of permanent complications over their lifetime. That's really the goal of treating Dupuytren. So that's what we do ideally. It's hard to predict things. It's hard this is based on our ability to know what was going on and how things were going to go in the future. We don't have, this is a summary of publications in the last 10 years that have looked specifically at these issues. We don't have a way to predict on an individual basis who's going to go from a nodule to a contracture. We have a lot of information after someone has had a corrective procedure, how likely they are to have a straight finger 3 months out. I'd say 3 months because it takes about that long for all the dust to settle after a procedure, even from a minimally invasive procedure, because people can have mechanical changes in their joint. So those factors are how bad the angle is, and the break point is about 40 to 60 degrees. When you're past that, you're more likely to have structural changes in the joint. Which joint is involved? PIP is worse than the MCP in terms of getting the finger straight. And which finger is involved? Small finger is the worst one. Once someone's had a procedure, the likelihood of having it recur, 3 factors I just mentioned, and whether or not the finger was straightened all the way. That seems to have an influence. Age at the time of the first operation, as I talked about, and how long it's been since the procedure, because it's an ongoing rate. So the longer you go, the more likely you are to have a recurrence. So these factors are in here, and it just means that the progression is hard to predict. And because of that, the actual management of Dupuytren often is really by trial and error. And so and there are a lot of different triage approaches that different surgeons have, but a fairly common one is, doesn't matter what you think what the biology is and how severe everything is, you start with the minimally invasive procedure because it's low risk, and sometimes you get a slam dunk. Sometimes you get an unexpectedly great result. And if that happens, you've dodged a bullet, and you've prevented that person from being subjected to a procedure that has a high complication rate, maybe with no benefit. So the point is, you want to avoid over-operating and you want to avoid under-operating. And so if a minimally invasive procedure works well and it lasts at least a year and it comes back, you can repeat it. It's pretty low risk, and you can repeat it. You can repeat it. There's a fair bit of information on the needle aponeurotomy. We're waiting for some information on Xiaflex, but I would assume it would be the same thing. If a minimally invasive procedure stops working well, if it doesn't work well at the onset, or if it doesn't last very long, the next rung on the ladder is an open surgery, fasciectomy. And if that works well and it lasts at least a year and it comes back, you can repeat it, but with a higher complication rate. If it doesn't work well, or it doesn't last long, then you talk about something else, which is kind of out of this realm. And that something else usually is for problems with the PIP joint. And so if somebody has a recurrent PIP joint contracture, one of the things to always think about is, do you want to do anything? And the question is, if your finger didn't ever get worse than it is right now, would you take on any risk to have it treated? So either people have a bend like this and they kind of get used to it. If it never got worse than that, it might be worth living with. And a lot of people make that decision. If someone has tried all these things and has gone down that path and they still have a bad result, it doesn't make sense to just repeat what gave a bad result before. And so I think that's not a good thing to consider. A more radical approach, like we mentioned, for people that have bad anatomy and bad biology, is to do a skeletal traction, digit widget, and a dermofasciectomy, because that has the best chance of long-term control. If those aren't options, then the common things to consider are, one is doing a PIP fusion. So the logic behind this, a fusion is when you make 2 bones grow together. You take the joint out and you make the ends of the bones grow together. So the logic is that if somebody has a joint which is stiff and bent in a really awkward position, it might be better to have it stiff and bent in a less awkward position. When you do a fusion, this joint doesn't move anymore. That's the benefit. it's also the problem, because if this joint doesn't move anymore, when you make a fist, it changes the way you make a fist. And people who play golf are not always happy with that. But that is one way to control it, and an option for somebody who's tried everything and they still have a bad finger. If someone's had a number of operations, they've had a number of complications, and they have a finger which is stiff and bent and hurts and numb, and they're just sick of it, and they think, I'd rather just, I think the hand would be better if I didn't have to work around this thing. That's the time that you can talk about an amputation. Some doctors will recommend an amputation, and I think that's just wrong. The request for an amputation should be a decision that someone makes on their own, thinking, gosh, I just don't want this anymore. People that talk about amputation in that realm usually have had 2 or 3 operations as a minimum, and have had complications from them. So that's an option that is not common, but scheduling an operation to have a finger removed, the most common reason for that is failed Dupuytren surgery. And more common than the next 2 reasons to schedule an amputation put together. That alone, for me, is kind of the strongest evidence that we need to work to have better options, because this is a benign disease, and for most people it's non-painful. And if you're talking about having control with an amputation, that means that the treatment options are inadequate. This is a picture of a digit widget, which is attached to the middle bone. This person has a bad contracture, and over time, rubber bands attach this gizmo to a splint on the back of the hand, and it just slowly pulls the finger straight. And it does a job that you can't do just with a splint. If you had a finger splint, the problem is the amount of pressure you need to straighten out, the amount of force you need to straighten out this joint and just stretch the fingers on the palm side is more than you can bear with a splint, usually. And the pinky finger's tiny, so the mechanics of a splint are really awkward. You really don't have much room to work with, particularly if it's bent. And so there's just too much pressure on the tissues, and it's painful, or people have problems where the skin breaks down, they get ulcerations. I'm not going to show you any pictures of that, but this solves those problems. But what makes Dupuytren better or worse? What makes someone have bad Dupuytren versus not bad Dupuytren, or progress versus not progress? The big risk factor is believed to be genetics. The other risk factors are not quite as clear, and an injury to the hand can accelerate Dupuytren, at least temporarily. Not clear at all if heavy manual labor makes progression more rapid. Not clear at all whether smoking and drinking or diabetes make progression more rapid. There's actually some not great studies that would suggest that people who have diabetic-related Dupuytren don't progress as fast, but the studies aren't well powered. Interestingly, the average person with Dupuytren is underweight compared to the average population. And people who are obese have a lower risk of having to have surgery for their Dupuytren. And there's a study 2 years ago, that big study, that concluded that people who were obese that had weight loss surgery, bariatric surgery, and lost weight, that actually increased their risk of needing surgery for Dupuytren. So I'm not suggesting that you go off your Ozempic and gain 100 pounds. But it's just one of these things that doesn't really make sense, particularly because if diabetes is a risk factor, people who are skinny should have a lower risk factor, and people who are obese should have more trouble. But another example of how Dupuytren is kind of like a puzzle with way too many pieces. Let's talk about nodules, a big part of treatment, and a big reason why people seek more information about their nodules, because people will go to their surgeon, they'll have a nodule, and the surgeon most of the time says, don't worry about it. Come back when you can't put your hand flat on a tabletop. That's not very satisfying, because then the person goes home, looks up Dupuytren online, sees these horrible worst case scenarios that are not common, but they spread rapidly. And so it's an issue. People don't want to ignore it. They want to be able to do something. And I think it's helpful to break down why people want their nodules treated. So some people will have nodules that give them symptoms. They're tender, they're burning, they're painful, they're in the way, they're aware of them, they interfere with activities, they feel them when they're steering or when they're trying to play golf, things like that. If you can treat those, you have an easy way to tell what is the benefit of that. Your symptoms get better. And that you can take as a benchmark to say, well, what would I be willing to put up with? What kind of risk would I be able to tolerate if there's a reasonable likelihood of making this better? Versus people who are anxious about their nodules. They don't have any symptoms. Their nodules aren't bothering them, but they've gone online, they know, or they have an uncle that had a bad result from Dupuytren surgery, and they just can't stand the thought of doing nothing. And I don't suggest that they do nothing. There are some things that can be done, although the evidence is not really clear one way or the other, but I think it's worth considering. So if someone has a benefit that they can actually put a number on or evaluate in some way, those folks, I think, are in a position to be able to say, what's the risk-benefit ratio? If people are worried about the future, we really don't have a way to assess the benefit of preventive treatments because we don't really have any well-proven preventive treatments. So if someone has nodules or knuckle pads or Ledderhose, they can be treated with cortisone shots. There's a drug called colchicine, which is an old drug that's used to treat gout. But anecdotally, I've talked to a number of patients. There's not been a big study on it, but I've talked to a number of patients who have been on it and on a regular basis, and it seems to reduce the symptoms from nodules and can make them smaller. Excuse me. And it's not something that needs to be done continuously. So I've talked to people who take it, and when they feel better, they stop taking it and see if it comes back. If it doesn't come back, they wait until they have symptoms again. If it does come right back, they go back on it. And that's a reasonable thing. There's work in England on injecting nodules with Humira, which is one of a class of drugs that's used to treat rheumatoid arthritis. Humira, Enbrel, Remicade, and a bunch of things that end in AB. And it turns out that with Humira, there's one factor that's involved with rheumatoid that seems to play some role in Dupuytren. It doesn't seem like it's a major role, but it's a treatable role. And the outcome of that is that if you inject nodules directly into the nodule and get the maximum dose of this drug right into the nodule, that can make the nodule smaller. We don't have any evidence to conclude one way or the other whether that changes your long-term outcome. And the logistic problem is you have to inject your nodules on a regular basis. That's hard for somebody to do to themselves. If somebody's on Humira for their rheumatoid, they can just give themselves an injection in their belly or their thigh. But with this, you have to inject it into the nodule, and you have to inject the whole dose into one nodule, so you can't split it among multiple nodules. So I think it's not quite ready for prime time. Radiotherapy, it's a big thing that's gaining a lot of popularity in the United States. Has been a common thing in Germany. What radiotherapy does is it can make nodules smaller, because remember, nodules are collections of cells, and the radiotherapy can kill those cells because they're rapidly dividing. That's why it works for cancer. So with radiotherapy, the protocol is to give a dose which is about a third of the dose that you give for cancer, and that makes the nodule smaller. Unfortunately, there's not evidence to conclude whether or not that prevents contracture down the road. So that's a problem with that. And there are risks with radiotherapy. They're small, but about a third of people who have radiation treatment of their nodules, the skin, it kills the sweat glands as well. So the skin can be dry and flaky, and that doesn't get better. And there's a small but non-zero risk of possibly getting skin cancer in the area, because radiation, whether it's from X-ray beams or sunlight on the skin, increases the risk of having cancer. Shockwave can reduce the inflammation, and there's early studies on this, both for nodules in the palm, just a couple of patients, and Ledderhose disease that makes it feel better and may reduce the size. Long-term effects we don't know. So those all have some risk involved with them. If the condition is to prevent something in the future and we don't really know what the benefit is, my take is to go with something that has a lower risk. And so just marching through, there are topical formulations. Voltaren is an anti-inflammatory medicine. It's in the same class as aspirin and Advil and Aleve, and it's available over the counter in a topical form in a alcohol-based gel, which is practical because we can put it on and it dries. Unlike other formulations, if you have something greasy on your hand, it's not practical because you can't have greasy hands and use your hands. So this you can put on, and it's an anti-inflammatory. So you don't want to use a big dose. So it's caution if somebody has a sore knee and they lather it all over their knee and thigh, you absorb a fair bit of it. But in a small area in the hand, and there's not that much absorption there, it probably doesn't pose much of a risk that I'm aware of. I wouldn't expect it to. And there are some folks that I've talked to that have tried that and have had some good results. Hard to predict. There's a company that sells, at least one that sells topical verapamil, which is a cardiac medicine that in theory should help because it is involved with some of the calcium metabolism that is maybe related to Dupuytren, but there's no evidence that long-term it makes a difference. And I haven't seen anybody who's used it on their nodules who's reported a great result. And then there's some oral medicines, which are in the nutritional supplement category. N-acetylcysteine is available as a supplement, and this has been looked at for other fibrotic diseases, and it's something that if you wanted to give a try, can't hurt, might help. If you take too much of it, it has sulfur in it, and so it can make you smell bad certain times. Quercetin is also a supplement that is found in broccoli and cruciferous vegetables. It's broken down by heat. So if you want a reason to eat more cauliflower and broccoli, that might help. The dose really isn't clear. And the problem with extrapolating things that you find in the lab to using them clinically is you don't know if you're talking about eating some broccoli or on a regular basis, or eating 10 pounds of broccoli for every meal. We just don't know the dose. And caffeine also that class of drugs looks like it might be beneficial. So if we're looking for a reason not to quit drinking coffee, which I'm glad for, that might be one. Magnesium, you'll read about topical magnesium that can really irritate the skin, but people in the Dupuytren demographic, magnesium deficiency is pretty common. And so it's not a bad thing to take anyway. And it might, in theory, have a beneficial effect. And sulforaphane is in a number of different foods, including kashi, which is buckwheat, and capers. I don't know how you could eat that many capers. And it's available as a nutritional supplement. All these have theoretical benefit when you look at how it influences cells in the lab. None of them have good long-term clinical documentation. The other thing you can do is we know that there's a mechanical aspect of Dupuytren. So if you're doing things that you can reduce the amount of mechanical stress on your hands, there are some things you can do. So bike gloves that have the fingers cut out so they're not too awkward. You can get those with silicone rubber padding in them that reduces the amount of shearing force and impact on the hands. People that work out, pull-ups put a lot of stress on the hands. There are these pull-up handles that you can get that have a metal strut that is circular that you can bury your weight and transfers the weight to your wrists. People doing push-ups or downward dog yoga positions, that stretches the tissue. And if you wanted to get around doing that, you can use push-up handles, or you can use dumbbells for that, or you can pad the ground with cloth and bury your weight on your fists. And in terms of working out with weights, instead of that, you can get soft wrist weights. You have to really shop around to get ones that are really soft, or else they're uncomfortable. Those are all things that you can do. Can't hurt, might help. And because we don't have a great answer, I think that's entirely reasonable. The other is that when you grip something, the narrower your grip, the more mechanical force it puts on your hand. And so if you play golf, tennis, racquetball, pickleball, you can, a reasonable thing would be to increase the diameter of your grip, go for larger grips. And that's a helpful thing, not just for Dupuytren in theory, but trigger fingers and tendonitis, because that's the same kind of situation. If you play handball, just stop. Now, controversial, splinting. So the background on splinting is that splinting is commonly used after somebody's had surgery, or even after minimally invasive procedure. It's recommended after Xiaflex. There have been a number of well-designed studies that have concluded there's no added benefit to splinting after surgery. And so that's a problem because you'd think it would help, but it's not been proven. I mean, it's been shown that it doesn't seem to make a difference. But that's after surgery, when you've fired up the biology by traumatizing the tissues. If you have mild Dupuytren or any, and you're not having a procedure, then Dupuytren, one of the things it does is it tends to just take the slack out of the tissues when you're at rest. When you sleep, your fingers are bent like that. So in theory, if you just reduce the amount of time that your fingers just sat bent, allowing the tissues to just tighten up the cord, then that might be helpful. The trick with splints is people in this audience are motivated, and it's a common thing for people to say, I'm going to get this splint. I'm not going to have trouble with it because I'm going to cinch this puppy up. So it really, really does it. It doesn't take much force at all to have too much force. And so listen to your body signals. You need to have a splint that's loose enough that you can wear all night long. Wake up in the morning and the splint is still on your hand. If you wake up in the middle of the night with the splint and take it off, it's too tight. And if you decide to muscle through it and just keep splinting and say, well, I'm just going to get used to it, what happens is you'll wake up with it and take it off in the middle of the night. You'll do that for a period of time. And then one night you'll have a great night's sleep and the splint will be on the floor. And all you've done at that point is you've taught yourself to take off your splint in your sleep. And at that point, you've lost control and you're done splinting. So you want it just so that your hands rest on it, not tight, not with, ideally, these splints on the left, the ones on the far left, I don't have any financial interest in this, are made by a company called, the product is Fix Glove. They're designed for Dupuytren. And the trick is they have bendable struts like the other splint, so that they don't have to be straight. You can bend them to just let your hand rest. And if it's too tight, it may be painful in 15 minutes, or it may even be a couple hours. But you can adjust these so that they reduce the amount of time that your fingers are all the way bent while you're asleep. And that makes sense to me, although we don't have any data to it. Can't hurt if you do it right, might help. Dupuytren's very frustrating. We wouldn't be here otherwise. It's frustrating because it's unpredictable, and it's frustrating because it's persistent. People that have the bad version of Dupuytren, the problem with it is that it doesn't settle down, and it just keeps slowly progressing, and they'll have a procedure to straighten it, and it keeps progressing and comes back, and that's the unsolved issue. But maybe it's not unpredictable. Maybe it's just we don't have a good way to test what's going on. We don't have a measurement of what's really going on with the biology. Maybe it's not persistent as much as we just don't have a treatment that can turn it off. That's most like the situation. And arguing about what kind of procedure there is kind of like arguing about which is the best broom to keep water off the beach. And you can debate that as much as you want, but it misses the fundamental question of what is the basic nature of water. And if you take that into consideration, you wouldn't even have this debate. I mean, they both work some, but neither of them are going to have a long result. Similarly, arguing about which procedure is the best procedure, and this leads into the argument of, gosh, if we just got an even better procedure, that would be the answer. If we just made the cuts in the right place, if we just injected the Xiaflex into exactly the right place, we would have the answer. That ignores the basic nature of Dupuytren, which is a biological disease. And what we need are medicines. We don't have any great Dupuytren drugs at this point. It's not for lack of things to test, because there's a long list of drugs, including some that I've mentioned, that have been looked at in the lab, or they've been looked at in other fibrotic diseases, or they in theory would help. Some of them have some clinical trial data like Humira on the top left. But But we have all these. And so which of these have been shown in well-designed studies to have good statistical evidence that they reduce the chance of Dupuytren progression or recurrence? And the answer is exactly zero, because we don't have the wherewithal to be able to do the right kind of testing. We don't have a biomarker test. And just as an example of how impactful this is, here are two hands. So the hand on the left has soft skin, and there's a well-defined cord. And this is something that a surgeon would say, oh, wow, this is going to be a slam dunk. The hand on the right has the skin is diffusely involved. There's no border or demarcation between the skin and all the way down to the bottom of the cord. And so looking at this, what's the difference between these two hands? Biologically, what's the difference between these two people? The hand on the right has obvious skin involvement. And people that have nodules, when they're bad, you can see these fingerprints really stand out. And that's a characteristic of active nodules. And she's had these nodules on her hand for years, no bent fingers. The gentleman on the right swears he never had any nodules, swears he's only had this for a couple of years, and he's got these cords. And what's the difference between these two hands biologically? The hand on the right, the person has these little narrow cords. They're literally like threads under the skin. And the person the person on the right has a big broad cord and obvious skin involvement. What's the biologic difference between these two hands? We lack a simple way to be able to put a number on these obvious biological differences. The reason that we're here is the difference between how surgeons approach diseases and how physicians or medical doctors approach diseases. So medical doctors, they're the ones who treat chronic diseases. And their goal is to prevent the complications of chronic diseases, like you get your cholesterol checked, not because it's going to kill you today, but it's a risk for having heart attack and stroke years down the road. Their expertise is biomarkers, like cholesterol. They treat systemic diseases on an ongoing basis. They manage diseases, diabetes, hypertension. Surgeons, on the other hand, have a completely different job. Their job is damage control, and they approach diseases as events. And their tools are to fix whatever the mechanical problem is. And their expertise is anatomy, not biology. That's not what they do. It's not a matter of them choosing to do it. That's not what they're called to do. They are called by the physicians when the physician's issues don't work. Surgeons offer local solutions, and if they do their job right, the goal is one and done, and the patient never has to come back to the surgeon again. And so these are very different approaches. And Dupuytren is, and Dupuytren is a chronic disease. So we don't have the biomarkers because the only thing medical doctors have to offer is a referral to a surgeon. So what surgeons use are anatomic evaluations and particular finger angles. So let's say we had a drug and we wanted to test, well, can this drug keep people with nodules from developing bent fingers? What you have to do with surgical criteria, you saw the numbers about what the risk is of going different ways over the next 10 years. So crunching those numbers statistically to do a power analysis of how big a study you'd have to have, the minimal size study, you'd have to have 1,000 people just with nodules, no bent fingers, treat half of them with the drug, half of them with a placebo, and continue that for 5 years, and then measure the angles and to see if there's a difference. That research is never going to be done because that is huge, expensive research. It's a big long-term study. Nobody's going to pay that. Nobody with a lot of money is going to pay for that. The NIH certainly wouldn't pay for that because it's very inefficient. And you'd have to get more people because there's dropouts and people would have reactions to the drug. So you probably have to start with maybe 1,500 people. So you could say, well, there's a way to compress this. Let's get the worst case scenario. We know that people progress more rapidly after surgery, after treatment than before treatment. Let that soak in for a second. People progress more rapidly after they're treated than before. And we know that, that if we worked on smaller joints and if we did procedures that had higher average recontraction rates, we could look at fewer people. So I crunch these numbers for Xiaflex. I think that'll be a great study. And doing a power analysis, knowing that somebody who has a PIP joint, which is most prone for contracture, that is already fully straightened out with treatment, we know that that person has a 40% recontracture rate 2 years after treatment. And because the recurrence rate is 10 to 20% per year, and this is like the worst case scenario to treat, a pinky finger PIP joint. But if you got those people, you could test your drug to see if it impacted the risk of recontracture. That looks like a smaller study, but it's actually not, because we'd have to take into consideration the fact that of people with bent PIP joints, at best, 70% will get a straight finger. So we'd have to not study the ones that weren't all the way straightened. And only 1 in 5 bent fingers has an isolated PIP joint in the range of 20 to 40 degrees, which is where you'd want to be so that you didn't get to the point that the recontracture was a mechanical recontracture, not a biological recontracture. So you'd have to start with a bunch of patients. And that winds up being a big study. There aren't single doctors that see that many patients. You'd have to get a bunch of doctors involved around the country. You have to pay the doctors to do this, or have pay them to have staff to do it. And so nobody's going to pay for this research either, unless there was some way to optimize it. It's just too hard to work. And the reason for that is that we're using the wrong measurements. This is what the kind of research that you have to do if the only measurement you can use is angles. That's a problem with all chronic diseases. And that's why the medical doctors don't base their research on developing drugs on physical exam. They use biomarkers. And the advantage of biomarkers, particularly in the blood, is that you can measure your results in real time, like cholesterol. Cholesterol is high. The doctor gives you diet, exercise, medicines, a variety of things. And then they let some time pass, weeks or months. Then they can measure the effect by getting another blood test. And that will predict your risk of having heart attacks and strokes down the road, or whatever you wanted to prevent. So this allows you to measure drug response in real time. So you don't have to wait years to see if there's a trend. And that's what we need to do for Dupuytren. If we had a Dupuytren biomarker test, we could do that. There's some hurdles to developing biomarkers. There's not a good animal model for Dupuytren. If you grow Dupuytren cells in animals, they change how the genes are working. Biopsy is not a good way to measure results because the act of doing a biopsy can flare up disease. So it's not like you give a drug and then re-biopsy somebody. That's not appropriate. And when you grow the cells in culture, grow them in a petri dish, very quickly they change. They're very sensitive to the mechanical environment. And even with the current models, we can't replicate what it's like to be in the body in the lab. And the cells change their gene expression very quickly. So we can't use those. And so the logical answer is blood. Now you might say, well, Dupuytren's in the hand. How is that going to show up in blood? And the answer is that our blood is the connector that helps our bodies regulate all kinds of things. So an example is, let's say you got a cut in your hand. You have a cut in your hand and it heals up. You might say, well, this is just, it's just there. But what happens is you get a cut, the damaged cells release these proteins into the blood that circulate through the blood. They ultimately circulate through the bone marrow. When they go through the bone marrow deploys all these special repair cells that dump into the blood. They circulate through and they find their way back to the area that's injured. And they start the repair process. So your whole body is involved with this, even if it's just a little cut. And the same thing is true with Dupuytren. There are some studies that have shown some abnormalities in the blood that are associated with Dupuytren. Not enough to test medicines, but it's clearly the way to go. So that's the best, the most promising avenue of developing biomarkers. And this is what medical doctors do when they develop treatments. Find the molecular markers, the biomarkers in the blood, use those to develop a blood profile. And that profile you can use to diagnose, is this lump Dupuytren or not? Staging, is this the bad Dupuytren or not? And to measure biologic response, is this drug working or not? Then we can take that information and use it ideally to find existing drugs that are already FDA approved for other indications and see if we can identify drugs that would also work on Dupuytren. And this is a big thing in medicine. There are a lot of drugs that have been repurposed. So Viagra was a blood pressure drug, and thalidomide was a sleeping pill, but now it's used for autoimmune diseases, and a long list after that. We check these drugs with clinical trials and then develop a standard medical management approach. With Dupuytren, we are at the starting gate. And this is the point of the International Dupuytren Data Bank. This is a registry that the Dupuytren Research Group runs. It's free online. People sign up for it and fill out follow-up forms to report their progress. We currently have more than 9,000 enrollees. Not everybody continues with their follow-up surveys. So we're ongoing process of recruiting them. And the goal is to get better information on the natural history. You know, the nodule progressing to a contracture. It would be great to be able to see, well, is this affected by the medicines you're on? Is this affected by other factors in your life? Because we just don't know. And to recruit research participants. A sign up for this is dupestudy.com. So we launched a pilot study 2 years ago, and it is currently underway. So we just cast a wide net because there's so much that's not known. We just thought, well, let's just look at as many things that we can afford to look at. And so we have 4 different kinds of gene tests. So we're looking at DNA. Of all the things, that's probably the least important one because your DNA doesn't change with life. And so it's not good to measure drug response because you're going to have the same DNA, whatever drug you take. The whole genome bisulfite is looking at these epigenetic changes that occur when you age and also when your body's subjected to stresses. And RNA, and small, micro, and messenger RNA, which are how genes talk to other genes. And that's all very dynamic. So the bottom 3 are things that might be promising to develop a dynamic biomarker test. And then we have 3 different types of protein tests because the genes work through proteins. The things that are circulating through the blood are proteins. And we're currently working on the protein analysis. The gene analysis is going to be a bigger project. We have 14 terabytes of raw gene data on 45 patients. So this requires cloud computing and cloud tools, and just logistically, it's a bit tougher. Our goal is to finish the analysis of the proteins, publish that data, finish the analysis of the genes, publish that data. Will probably be by early next year, fingers crossed, and then deal with the fact that this is very complex analysis. These yellow circles are 5 of the genes that look like they're probably involved in Dupuytren. And the other circles are other genes that these interact with. And this is just 2 degrees of separation, like the degrees of separation from Kevin Bacon. And it's just cut off there. If you extended it to 5 or 6 degrees of separation, it's huge. And so it requires a special type of data analysis. And this is ongoing. Our goal, I went to the NIH years ago to ask why they weren't funding Dupuytren research. And they said, well, it's because nobody's done this kind of research and shown us the results. And the NIH doesn't fund research without having some evidence that they should fund it. And so you have to do a pilot study and then go to the NIH and give them the data and say, well, this looks encouraging. Put together a grant for a couple $1 million, and we're going to reproduce this on a big scale so that we can really get data on it. So that's what they told me. And so it took years to raise the money to do this pilot study. The budget for the labs alone was $400,000. And so, which is tiny in medical research terms. You talk to somebody in pharma and that's, that's pocket change. But that is what we have to work with. And our goal is to get the data, to make the case, to pitch this to the NIH to fund Dupuytren research. Because this research is expensive and we just can't do it without some kind of big grants. And no large Dupuytren grants exist. NIH grants in the process that we're going on, let's say that it's a big bureaucratic machine. And so you have to give them the data, and then it may take a year or 2 for them to decide they're going to fund it. And then typically it's 18 months from them announcing that there's a grant and having somebody win the grant, of which only 3% of applicants get, and then they don't get the money for 18 months afterward on average. So we're talking probably 5 years, if everything goes well, before there's substantial money to do additional major research. The pharmaceutical industry, in terms of preventive treatments, they really can't get involved until there's some way for them to prove that the drug does what they say it does. In this case, prevent progression and recontracture. We can't really wait for that. And the progress of doing research, we're not just going to sit on our thumbs waiting for grants to come out. We need to keep going with this, and this is expensive stuff. I'm an advocate. I'm an unpaid volunteer. I donate generously to Dupuytren Research Group every year because I believe in this mission, and I want to make a difference for people who are struggling with this disease and their family members who are or will be struggling with this disease. And so I need help, not just financially, but I also need, this is a complicated project. And so I need any experience, knowledge about how this works, knowledge about how to run nonprofits, development, fundraising, all of those things. And I encourage anyone who wants to chat about this to get in touch with me. I'd like to have a one-on-one conversation to see how we can improve what we're currently doing. This is a big, important project, but it's just a little tiny group that's doing it. And so I'm asking for your help in any of those arenas. Together, we're going to do this. It's just going to take time. And so resources, dupuytrens.org is our website. We just got a new website launched yesterday. So now we're trying to figure out why things don't work on it. And so wait for a week or so, going back and forth. The International Dupuytren Data Bank, to enroll in research, tell your friends whether or not they have Dupuytren, because we need controls as well. Dupestudy.com. And for financial support and charitable giving, curedupe.com. And these are ways that we can work together to make a difference and change the future of Dupuytren disease. So that's my story. And let's talk.